Welcome to the Heart of Prevention, helping clinicians stay up to date on preventive cardiology. This show features leading experts discussing real-world strategies to prevent heart disease, from lifestyle changes like diet and exercise to medical treatments, including new therapies. Whether you're a medical student, resident, or practicing clinician, this podcast challenges, informs, and enhances your approach to cardiovascular disease prevention. The Heart of Prevention, keeping hearts healthy one episode at a time. I'm Dr. Michael Shapiro, President of the American Society for Preventive Cardiology, and now here's your host, Dr. Keerthana Pakanati.
Dr. Turakhia, Dr. Martin, Dr. Bhatt, welcome to the Heart of Prevention.
Thanks you. So great to be here.
Thanks so much. Pleasure to be here.
Thanks a lot.
I'm Keerthana Pakanati. I'm the host of the podcast and a current cardiology fellow. Before we dive right in, I'm going to talk a little bit about our guests for today's episode. Dr. Bhatt is the Chief Innovation Officer at the American College of Cardiology and the chair of the inaugural Digital Health Advisory Committee at the FDA. Dr. Seth Martin is director of the Advanced Lipid Disorders Program and Digital Health Lab at the Chickaroni Center for the Prevention of Cardiovascular Disease. It only took me 3 episodes to get that name pronounced correctly, but I think I finally got it. He's also on AHA's National Health Tech Advisory Group and the president of the National Lipid Association's Southeastern region. Dr. Mintu Turakhia is the founding director of the Stanford Center for Digital Health and the Chief Medical Officer, Chief Scientific Officer, and Executive Vice President of Product at iRhythm Technologies. So we're going to start off with probably my favorite question to ask as the host, but I'd love to hear a little bit about your own personal journeys and really how you arrived at the careers you have today, including your interest in innovation and digital health. And we can start with
Great, thanks. I'll try not to take up all this time because roads are never straight. They always kind of take multiple directions. Short form is I cared for patients who were young, adults with congenital heart disease. So they really pushed me to start thinking about better ways of connecting. And so when things like FaceTime happened, they said, well, why can't we FaceTime? And so it was really my patients that drove me to say, hey, how do I better achieve getting you care in the community where you live, both by me, then eventually by imaging, then by population health and screening for people in the community and helping them get to care. And so it was really my patients who drove me towards thinking about digital health. And then nobody was interested. Between 2013 and 2020, telemedicine was not favored by people. It was not really well compensated. Digital stethoscopes were early. Maybe some handheld ultrasound was out there, but it was very fuzzy. And I really think that the COVID shift made people realize that we needed to have better ways of reaching people in the communities where they live. And so that's kind of how I ended up taking what in my clinical practice was a side interest of mine and really making it a main driver for my career, which is how do we get high-level cardiovascular care into the communities where people live? And to do it, you need to be an innovator. You need to do digital health. And you need to now really think about the ideal compute power and AI.
Yeah, I love the fact that you said your whole journey really came from your patients, because I think, the idea to innovate and create things, we have to think about who we're actually helping, especially at that ground level. Dr. Martin?
That resonates with me, being inspired by patients. I don't have Ami's congenital expertise, but coming at things from a preventive cardiology standpoint, I knew during my general fellowship that I was going into preventive cardiology. And it really struck me that we know so much about what we can do. But there's this huge implementation challenge. And so as I went to clinic and you see people every now and again, whether it's every 6 months or a year or sometimes more frequently, that we have this, episodic care system and we try to coach people on their lifestyle and on the evidence-based medications, and there's just these huge gaps. So as I kind of reflected on that and saw, it was around that time that wearables were starting to catch on, digital health was growing, and I just saw the opportunity to be a problem solver from that standpoint. And it was kind of in parallel to my research at that time was big data research, and I was working with lipid database, and the journey there started with showing a problem and ultimately developing a solution related to LDL cholesterol calculation. And that kind of shift in mindset towards being a problem solver and wanting to do more on the the intervention side of things, I just felt like digital health was really conducive to that. And so it was started with kind of seeing that clinical problem, wanting to have a way to better support my patients between clinical visits that led me to get into the field.
Yeah, I love that. Thank you. And then last but not least,
Thanks again for having us. It's great to be here. It's fun to be here with Seth and Ami because I've had the privilege of working with them over the years. I'm an electrophysiologist and not really what people think of when they think of prevention, but there's a lot there that we aim to prevent, and we can talk about that. I grew up in the Bay Area in California, and when you grow up in Silicon Valley, many of us just wanted to be the next Bill Gates or Steve Jobs at the time. What changed that trajectory for me was visiting India, actually. And my grandfather, who was at one point in his life a cardiac surgeon, decided to go back and just hang out and be a general practitioner, a highly overqualified general practitioner in a small village. And then you realize he's working with suction bulb electrodes and a stethoscope and a reflex hammer. That's all he really had in his office. So at that point, you're on the world of computers and you're like, oh my God, what's going on here? Also in India, pharmacists can prescribe. So it's this huge opportunity to start thinking about diagnostics and the potential in health. So I came back and started working on wearable technologies to be used in research. I was not smart enough or brash enough to be an entrepreneur, so I did the next best thing, which is become a doctor. And over the years, it's been a great journey. Being at Stanford, working on great science, seeing patients, starting our Center for Digital Health, and then eventually deciding, you know what, are there different ways to have impact beyond kind of the academic and clinical one patient at a time circle? And that led me to iRhythm.
yeah, I loved hearing about your journey and kind of seeing the experience from India to now. And everyone's been very inspirational with their stories. Kind of pivoting a little bit, we all talked about patient-centered, patient-focused care. What role do you really see wearables, remote patient monitoring? I'm learning all the terminology as you guys talk about things, like taking mental notes of what I'm supposed to call things. But, what role do you really see wearables, remote patient monitoring playing in risk factor control, particularly in the prevention space, which we know has a role both in adult congenital and EP. And I love the fact that we have three different, specialties really represented here. We can start with Dr. Barton.
Great. Thanks, Keerthana. So yeah, I mean, I see a huge role here. I think it's digital health, AI is going to impact every part of the patient journey from wellness to diagnosis to management. There's been a lot of interest around RPM, remote patient monitoring. And Mintu and his team covered that, I think, in your recent New England Journal paper really, really well. And I think that there's the reimbursement on that front and the way that that's caught on in the hypertension world and so forth is a really good starting place. As we think about the role of digital health, though, it's much more than monitoring, right? It's about the management side of things. So I think as things evolve, it's going to be it's going to be very much about how we pair the measurements with action to improve those measurements. Something like blood pressure is a little more conducive than my world is in the outpatient setting is lipids. I have a lipid clinic. That's not as conducive to like a digital health tool measuring the lipids. It still, I think, is going to remain largely like going into a lab and having your blood
Right.
checked. Although you can have home checks as well, but I think it's largely going to be lab based. But but yet digital health technologies can still be quite relevant in the sense of you can be monitoring adherence to proven therapies. Obviously the lifestyle is healthy behaviors through lifestyle, the foundation of prevention. And so digital health really plays well into that. So I think certain things are maybe easy, different aspects of these risk factors can be measured at home. But I believe that increasingly we're going to have programs that can address one risk factor or multiple risk factors driven by digital health technology, helping educate patients, drive their engagement at home, but also providing then that collaboration with the clinician who will just have better data when you're seeing them virtually or in clinic. So there's tremendous, I think, opportunity here. And RPM is kind of one component of a much broader set of sort of how digital health will influence clinical care. And it's it's a great start. But I think one of the key pieces there is that there is reimbursement. We're obviously going to need, the right reimbursement or business models for this all to work.
Yeah, that makes a lot of sense.
Yeah, those are some terrific points. We've been talking about RPM for a very long time, and it hasn't really scaled except in a few places. And it's like many challenges in healthcare is a large misalignment of incentives. So in California, hospital at home has not, or hospital to home, or whatever you want to call it, has not worked because of various commercial and union interests. Whereas it has worked in Massachusetts because there are structural incentives by the state that AMI knows really, really well. And so that's one problem. The second is the term monitoring is a tough one. Like, what is monitoring exactly? What are you supposed to do with it? Is it continuous telemetry? Is it your consumer smartwatch? Is it something else? I mean, we have the technology to monitor, quote unquote, many things. I work for a company that does long-term continuous ambulatory ECG monitoring. That has a very specific use case, but it could have a broader use case in the context of other diseases. We are very early in our ability to understand and use cuffless blood pressure measurement, which is a very polarizing topic for very good reason. There's been a lot of emphasis on this topic at ASPC and other places, and we can talk about that. So we're sort of still in early days. There is tremendous potential. I think fundamentally what we have to understand is we've disintermediated structurally things from each in healthcare. So the diagnostic no longer requires you to see your doctor. It's at home. What does it look like? Do you get a lab test, DoorDash, a lab technician, and do you get DoorDash for blood test, or do you move non-invasive? Like, we don't know yet, but it's moved away. Okay. Now with language models, AI, and other things, arguably the clinical expertise and decision making not only is disintermediated structurally from brick and mortar, we did that with remote visits, but it may be disintermediated from the actual physician synchronous time. Right now, the care you get from a doctor has to happen simultaneously in your interaction, right? So now you have disintermediated time. And then the third thing that we have to work on is treatment and disease management. That's the benefit of monitoring. So when you get to a point where someone can self-titrate or self-manage with appropriate clinical oversight their heart failure, hypertension, or AF, or cholesterol medicines.
So I'm so excited. There's so much here. Let's just take it as a story for a second, right? You were asking about cardiovascular kind of risk factor and prevention initially too, right? And so even if we draw right back out to that, I'm going to take off any adult congenital hat. I'm just going to put on like global policy healthcare hat for a second. Remote patient monitoring, Mintu's right, around for a long time, and it is coming closer and closer and closer to our patient, right? Wearable industry just coming right for our patients from this direction. And in between is this gap that we have, where we have our healthcare industry, we have our wearables, and we need a culture change to close that gap. And that culture change is that we really haven't given patients agency. It's one thing to teach a patient. It's another thing to ask a patient to be responsible for themselves. And so the phrase I used earlier this year, and it's, I don't know, I'm sticking to it for now, is it's not really consumerism. It's patient agency. We have to let them be that excited, and then we have to give them some infrastructure as to how to help close that gap. And so what can we do right now? Mintu and Seth both kind of alluded to AI. We can screen. We can now screen the population and tell you who has what risk factor where. What we need is the infrastructure to say, once you have been screened, is it you managing this with the things you can buy over the counter? Is it someone prescribing something for you that you're going to use? Or does a doctor need to come in and do it? The truth is, for different risk factors, depending on who you are, it's a combination of those. And again, the infrastructure for that care is missing because we keep trying to go at it in a paternalistic or maternalistic way. Like, I am telling you how to do this, rather than engaging our patients in being responsible. And so I think that's a big part of it. While we're doing that, we don't have enough doctors to do this care. Never mind cardiologists, PCP, nurse practitioners, PAs, you name it. And so we really need to upskill people in the community to be able to understand how to take these risk factors and make them actionable. And so I think that's where AI and generative AI is going to be really helpful. Don't give Seth, Mintu, and I generative AI. I mean, you can give us generative AI, but please give it to those who need to tell sick from not sick. who need to initiate some form of basic care where it's not a very sick patient needing home hospital that we are providing. And so I think when you put that whole story together of look where we've come from being in a hospital to the community to the patient, look where wearables and other things are starting to come. By the way, we demand FDA approval, and we can talk about that later, right? For some of these things to really get there, that's very important. And yes, they need to do that. And as we do those things, then start to create that infrastructure of screening, notifying, educating the patient and the clinician, and then helping people who are closer to the patients than we are in the community to understand what they need to do, because we can't manage everybody out there. We just
Yeah,
can't.
and if I may, Keerthana, I want to just build on that point. So, screening gets into two things. It gets into where's the data, what are the outcomes, but it feeds into population health. And so in my world, take evaluation for undiagnosed arrhythmias, which some people call screening. Well, US PSTF says not enough evidence yet. We have a ton of trials. They show that you can find AFib, but the actual stroke rates are low. They've not really looked at what I think is the right outcome, which is cardiovascular hospitalization and heart failure, which is more common after AFib than stroke. The incidence of stroke has gone down in the general and the AF population. But the problem with any diagnostic is the link to therapy, as Ami said, right? So if you get some notification on your watch that says you have AFib, it's great in concept, but only if it's acted upon. The same is true of screening of anything. If you were to do a randomized trial to screen for blood pressure or cholesterol, none of it's going to matter unless there's compelling treatment. So, one of the things we've been sort of pushing at iRhythm and been successful is the idea of population health management with value-based payers, Medicare Advantage. So we can take whatever risk profile you want, everyone over 65, 65 with comorbidities, and more recently, some statistical learning and machine learning algorithms to help identify patients who are likely to have undiagnosed arrhythmias, do a program in that Medicare Advantage plan. The difference is you tie it to care that's delivered at scale virtually to make sure they get on the right drugs or therapies. And then we're going to look at outcomes, right? So we can spend 10 years doing the right trial and then get into guidelines, or you have these great test environments called value-based care, which are willing to take on risk to see if there's downstream value and outcomes. And we and others have been very successful there. And I think a lot of our evidence in prevention is actually going to come from Medicare Advantage, which is a group that if you're in the fee-for-service ivory tower in large health system world, you don't really get to see.
There's so much to unpack there. Did you want to say something, Dr. Martin? Yeah.
I know you have more to
No,
go
this is great.
to go on,
This is
but
great.
this is a great discussion. Because everything that Ami and Mintu are saying really resonates with me. And I think one thing to just note is that in the current, I think we're all agreeing that monitoring is not enough and RPM hasn't really fully been successful and scaled. And one thing is and I completely agree with what Ami said around patient agency or putting patients in the driver's seat, because right now, if you send all these data to clinicians, there's not enough time to deal with all of this. We already have wait lists that are very long to get into our clinics. We can't. It's not there. That is going to be a rate limiting step to scale of the. And so we really do need to put agency in the patients, given the shortage of clinicians and just the fact that this is a continuous thing that you manage. And so maybe we'll have time to talk about some of the programs we've worked on in cardiac rehab and post-MI, but that's very much resonates with me that it's about putting people in the driver's seat to have that self-management, not always relying on sending it to a clinician who's going to spend a certain amount of minutes to review the data, and that may or may not translate to better kind of therapy and outcomes.
So every time Seth said it, I'm hearing a different word than the one we're using, right? Instead of agency, which is urgency. And I'm thinking a little bit about our cancer colleagues and how I have a massive cancer chip on my shoulder about how well they generate a sense of urgency, right? Now, having said that, cancer is a horrible disease. There should be urgency. Heart disease is a horrible disease too. It outnumbers the rates of cancer in many places across the globe. And yet we don't feel the same urgency. And so I think that is actually part of what we need to do as a community as well. We say prevention as if, years from now, something may happen. And even when we call it prevention, it sounds like, well, eventually I'll get to it. And so I think there is that sense of urgency. We need to find it. We do at ACC have driving urgency and LDL screening. We have corporate partners doing it with us because you need dollars to get out there into communications and marketing campaign. You need to be able to reach people in the communities where they live. And so this is a public-private partnership, right? Industry, academia to do that. But I think driving that urgency is actually really important as well in terms of then getting local clinicians or patients to understand why it is that this should be partly their responsibility, right?
Yeah, for sure. I feel like based on what we were talking about, kind of one of the things that I was thinking about, and maybe this is, again, just my naive standpoint, and so I'm really excited to hear your thoughts on this one. In my head, I think about different patient populations based on what institution you're at, what city you're at, health literacy for that patient population. When I think of digital health and kind of educating myself about it, what are your thoughts about making sure that digital health doesn't necessarily widen health disparities? And I know we've touched upon it a little bit with the fact that like you're giving patients agency and you're kind of, if anything, you're empowering patients. But what are your thoughts about digital health and how to avoid widening health disparities given uneven or unequal access really to technology in general?
I'll give shorter answers
I
now.
can give it a shot there.
Yeah, go. And we're going to work
Yeah,
on shorter
so
answers for you,
we
Keerthana. Sorry.
again, this is a conversation that has been talked about ad nauseum, and there's sort of two issues. One is like, well, what's the control population? Is it high quality brick and mortar care, or is it no care? Right? Like, what is the control? And the second is like the technology is everywhere, right? So the question is, how do you turn it around in a way that makes sense to deliver to those who need it most? And I'll give you one example from the company, I'm at. So during the pandemic, we all know that people couldn't go to the doctor. But if you had syncope or if you had symptoms, you needed ECG monitoring. We have a product that lends itself well to be mailed to you to put it on and wear it, right? So now 30 to 40% in 2026 of the 2.5 million we do in the US alone are what we call home enrollment. It's just mailed to the patient. So the working mom who has 3 kids and is juggling pickup and work does not need to go drive to a hospital, pay for parking, wait in line to get this thing, right? Um, it's multilingual. There is text messaging. Well, there are apps, including a Spanish localization that's coming soon to help people, which says, hey, it's in the mail. Like it's like Amazon. It's tracking. It's coming. Here's how you put it on. Here's what you can and cannot do. Okay, great. It's time to take it off and send it back. If you don't have an app and if you don't have the right smartphone, we'll text you. So you just have to kind of meet people where they are and deliver the care at scale. At the end of the day, if you can design your products in a way that does that, you will be reducing disparities. The other thing is we're an insured product, Medicare, Medicaid, et cetera. So you get away from having to buy a consumer thing to monitor your health. And that whole area of wellness blurring into high cost premium longevity products is, I think, where you see the disparities. But so for sort of core bread and butter diagnostics and remote patient monitoring, in my opinion, I think there's an opportunity to make them accessible and to narrow any perceived divide.
I was on rural health radio recently, and it was amazing the number of callers and the conversation that came on that show about giving people more access and the assumption that many people carry that rural areas are not populated by people who are able to use this really quite user-friendly technology that the people in a city or, living in a high-rise in Manhattan can use. And so it was very interesting to just hear the reactions of people saying there is a bias that's really not based in reality in a lot of these conversations. And if offered the right technologies, we can find a way to do it. Verizon has an innovation center here in Boston. We were just there recently as well. And they're very clear on the fact that there are ways to reach people and give them access to healthcare that can involve things like downloading stuff at night, right? Like, when does the upload happen? You don't need 5G for everything to work, right? And so all of those things are true about when people say, well, we don't have the technical infrastructure. Well, actually, the technical infrastructure to get some of these things to work is really quite basic and already exists in a majority of places. So I think some of those assumptions, when I hear this question asked now, because Mintu's right, we've been asking it a long time. When people say, well, is it going to worsen the digital divide? I have to remind people that we are assuming things about populations who have maybe less than others without actually going in there and looking at the modern day version of it. And I think, yes, there are areas that are still, under supported, and that's true for education. That's true for other civic needs. But we should go in there with the assumption that we're going to try and make this work. And so how can we try and make this work? And I think that approach is really important.
The optimistic view here is not only will we not worsen disparities, but that we actually will improve health outcomes in the broad population through the use of digital technology. Of course, people need to be able to access the tech. It needs to be usable at the right reading level. That's and there has to be the evidence there such that people can get it paid from through their insurance. But I think there's then the opportunity that by improving access to care, like Mintu said, they're busy, they can't come in for the appointment for the hookup or a medical appointment, but they can fit in a brief visit during their day, or they can do things asynchronously, and then that can result in better outcomes. I think we could flip the story a little bit about it not being about worsening, but actually improving the health of the whole population by just using these tools to improve access to care and possibly provide care more efficiently with better outcomes, such that we can actually afford to scale things up and provide more care for people. So I think it's a real concern. There are real ways that we could worsen the digital divide, but also I think if we do things right, it could be the total opposite.
The other area where we might want to just acknowledge there's perhaps a bias is a little bit of ageism when it comes to using digital technologies. I do think that there is a role for increased support for all people. We make assumptions. You have the guy who's wearing his suit and going to his executive job, and therefore he's absolutely going to be able to do this. Well, maybe he can figure it out for himself, but he's also caring for an aging mom who's alone, right? And so, there needs to be some form of support for everybody who's trying to engage in this. And if we look at pill packs today and you watch, a grandma trying to open there are now, obviously there's some companies who've made a lot of money over like better looking pill packs. However, saying that, there's a lot of things that we do where we're not considering special populations. The aging population is growing, but to make an assumption that some of this technology is not usable by them, rather than saying, hey, how do we make it most usable by them? How do we support multi-generational families trying to do preventive care for people younger themselves and people older? What is happening to the sandwich generation? I think we need to really start doing digital health if we're going to do population health with these people in mind, right?
Yeah, and just quickly, I think it's a real issue, but it's not. I think it's less about the direct access to the technology. It's the implementation and then what you do with the information, right? So okay, so yeah, I can say we can ship an ambulatory ECG patch, but if you live at a place where people steal boxes off of your porch based on your zip code, that's a problem, right? Now, you're not going to want that. Or if there are other cultural issues or issues around literacy, even if that box comes to you and you open it and you're under the impression your doctor prescribed it, do you trust it? You trust taking this thing and putting it on yourself and wearing it for 14 days because you have instructions from some company and a doctor apparently told you to do this? And are you going to mail it back? Or if you have a consumer thing that tells you about your sleep or activity, will you have enough literacy, agency, and activation and resources and means to act on that and seek the right care, right? So those are super important areas, and I feel like that is less about the technology and more about the general problems we think through in healthcare.
And one of the things about generative AI now is there should not be this like a public service announcement. If you are a new young company out there, you should be able to translate everything into every language. Generative AI makes it easy. You should be able to do it at the language level of the appropriate. You can do dialects if you need to. And so I think part of that communication now becomes a lot easier to do. Now you have to account for it, do it correctly, budget for it, et cetera. But there shouldn't be a reason that you're not fully accessible to people nowadays. And that's maybe different. It should have been that way 18 months ago and previous, but now it is that much more obvious that that's something that you should be able
Yeah, it's a great point. I think there's an opportunity on the regulatory side. So now that I sit and help make products, labeling, instructions for use in different languages, that all has to go through human factors testing and a lot of different things and labeled approvals. And which isn't to say you shouldn't do it, but if the pace of translation and human factors testing is now accelerated, there should be a faster way to be able to get those things cleared and able to use with often our ancillary software products, right? So the translations may be in an app, not necessarily a 100-page booklet like you get with your washing machine in like 60.
That's right. You guys are watching history happen. Message received, Mintu, Turakhia.
No, I feel like, a lot of the points you brought up, I think it's just educating ourselves, especially putting myself in the zone of a trainee who's learning all this kind of on the fly from people that have had to figure it out on their own and now try to educate us about it. I have a little bit of a selfish question, I think, but I'm going to ask it. For fellows and early career physicians that really want to not even just get into the space, but understand the space and be able to like really support the movement of digital health and understanding kind of what's going on and educating themselves. Where should we start?
I'm going to offer the following. The innovation section of the American College of Cardiology is very willing to take new members. It is a great opportunity to continue doing your day job, but start to just get exposure to what are companies like? What is it like to work with them? What is it like to sit with Mintu's team and say, here are the things I need, and watch them say, well, here are the things we need to get this done. And so I would say to volunteer to do that. Now, you don't only have to do it through the ACC. You can also do it through your own institution. You likely have an innovation group. You likely have a digital health hub now. If you don't, you likely have a health equity hub or an area that's trying to get into the less well-resourced areas. $5 says that those people are trying to use some form of digital innovative technology to get there. So I think just letting people know in your institution that you're interested in this opens a door. And for those who don't know very much right now, which is a lot of us, we're always happy for you to learn and teach us and talk together. That is still true. This field changes so fast that there's not going to be a point where you say, I am an expert. I think I'm going to speak for Mintu, Seth, and I, because we've all known each other for a while. None of us consider ourselves experts. We are constantly learning that there are things that we don't know. But if you feel like you're like that, then you're one of us. So just, find us, approach us, ACC Innovation Program, locally, let people know it's an interest of yours, and you'll be surprised how quickly your career can grow.
I would second that. Yeah, for sure. ACC's been a leader, fantastic in this area. Of course, this is an ASPC podcast. ASPC has a growing digital health AI contingent, and I think opportunities to help fellows build this. There was attending the meetings, whether it's the ACC meeting, as well as ASPC just had dedicated sessions to this at Boston. So, and AHA has great programs that we've been involved with for years. So I think the professional organizations completely agree, would second that. And I would push fellows to think about in your current clinical practice, are you leveraging digital health technology to the extent that you can, and where are the areas where you see the greatest opportunity, and possibly develop your own new project around solving a certain clinical problem, either working with a lab that's already, working in that area, or developing something totally on your own with the right mentorship team. I think that's a way to go really deep into the field if you have a dedicated research project in this area.
So there's this really interesting article that came out last week in the New England Journal called Educational Strategies for Clinical Supervision of Artificial Intelligence Use. It's super interesting. It's very forward-looking. It is provocative, and it gets into this area about the development, like what's going to happen now with this current generation and future generations of physicians, where you've thrown GPT or a language model into the mix, and they talk about AI enhanced learning and practice, but then they also talk about getting de-skilled and what they even called arrested development. Like, it's super interesting, right? So medicine is changing, medical education is going to change. What we are expected to know is going to change. And what you don't want to do is now you're just having a conversation with a patient in the room just on GPT. Like, I've literally had situations where my team has interviewed recruits for our company, and there's awkward pauses, and it becomes clear that the interview candidate is throwing in the questions into a language model, and that's the delay, because they're not able to say things. Like, you don't want that in medicine, right? In terms of practice, and people are like, well, should I only do a procedural specialty? Do I need to get a data science degree? It used to be, do I need to get a degree in clinical research? Now it's, do I need to get a degree in data science? Or, hey, like, we don't know. And I would like to say you should just do what you want. That's what got all of us here. And there's no reason that fundamentally changes no matter what you read on social media. Um, but the practice and education will be different. We just don't know what that looks like. And there could be a world in which you start having procedures be done at some level with a level of AI support that doesn't exist today.
Can I'll do a selfish little play here. We are looking for any volunteers who want to do some chat GPT style, so large language model testing, seeing whether or not retention changes. So if anybody's interested, abot@acc.org. We're really trying to just figure out what happens when humans interact with AI when they're responsible for someone's care. And so it's an area that really does need to be studied. If you're interested in either participating or doing that research, just reach out to us. And again, yes, ASPC digital health, also a very important area to go to.
Yeah, I feel like we could talk for hours and hours about all of this. And I think what's awesome for me is I feel like even just my understanding and our conversation has already changed. And I feel like there's so much opportunity for, education and especially for us trainees just to understand more. So that's lots of exciting opportunities, guys. Y'all heard it here first. I did want to ask a question. You all talked about how you're continuously growing and you've seen how the field has changed and there's always room for growth. And I want to know, where do you really see digital health and in prevention, but also in, cardiology in general and in health in general? Where do you really see this headed and the biggest opportunities in the next really like 5 to 10 years? I would say. I think this is a good kind of conclusion question.
I'm happy to kick this one off. It's partly like kind of what I touched on earlier, why I got into this in the first place. It's a chance to close the implementation gap. Ami, I think you were part of a leadership page in ACC where you talked about the what and the how. Like we know so much about what we can do to benefit patients, yet it gets implemented in a very incomplete way. When you look at everyone that could benefit. And so I think this great opportunity is to help use digital health from an implementation standpoint to engage patients, to get these therapies adopted, to drive that patient-clinician collaboration. And so we're going to need to achieve scale. So much of digital health has been kind of on a like pilot level or small scale studies that never then make it out. I know, Mintu, like we've talked about the death by pilots, and that's been so much of the digital health field. So I think the big opportunity now in the next decade is to actually overcome that, and for those technologies or programs, strategies that are actually working, we need to figure out how to scale it up so that we can actually reach the masses. Because otherwise we could have a great intervention, but we're having still a small sized impact on a scale because we're only reaching a tiny part of the population. So I think it's going to be about scaling up the things that work, that are really about it's not a new drug, it's not necessarily a new treatment, it's just actually helping more reliably implement what we know works?
Yeah, I think the two biggest opportunities, well, in the US for sure, is alignment of incentives. There's just the incentives are presently aligned for fee for service, which cuts against everything you hope to accomplish in digital health. There are more Medicare beneficiaries in value-based care than ever, more than 50%. It's going to continue to rise. But what about pre-Medicare? That's, to me, where the big opportunities are. So we got to figure out how we do that. If we can do that, then everything unlocks and opens up. Incentives, regulation, having a coherent framework, giving patients their agency, as we discussed. The second is global. So, like, the global potential is real. And it kind of goes back to what I started with my grandfather, with his little suction cup ECG and a stethoscope. So, the extreme outlier of the ability to find mitral stenosis in a village in India is having a cardiac surgeon who puts down a scalpel and goes to a village. Well, that's great, but if you really want to scale that, you scale the stethoscope that can recognize these murmurs autonomously, right? Whatever the diagnostic is, that's what has to happen. There is a change that I actually noticed in India when I was there earlier this year, where the millennial generation in some of the big cities, and I'll speak for Mumbai, they're like, I need AI. I don't want to see a doctor. In fact, the pandemic has created a lot of mistrust with doctors in the fee-for-service world and in the management of their parents or grandparents or loved ones during COVID. It's a whole other conversation. But like, they're ready for this. They want to broker their own healthcare. They're like, where's the tech? I mean, Amazon Prime will deliver something in India to you, not within days, but within hours, right? So it is ripe for healthcare. So I think global opportunity is huge.
The great thing about going last is I can progressively cross a bunch of things off my list, and it leaves me with 3. By the way, global was a big one on my list. I'm so glad you said that. The suction cup thing totally resonates, by the way. Real world evidence. Please fight for it when it comes to these kind of technologies. A randomized controlled trial for a technology that's going to change during the period of time where you do the randomized controlled trial. I'm not saying you don't need them. I'm saying we need to figure out how to do real world evidence right. For those of you who are aiming for being trialists and thinking about publishing and thinking about setting this up, please think about, really pushing that field forward when it comes to digital health. The second is advocacy. As much as we say clinicians and hospital systems set the way things are done, we don't. There are policy, there are laws, and there are people who really want to learn from us. So please advocate, go to the Hill with whichever group it is that's going, talk, tell your story, and see how those engines work. It's really important to do that, and we have to be a strong lobby for ourselves and our patients. And the last is, please direct industry and VC. Direct their systems. They have great systems of how to do things. They have a great number of dollars that they invest in things. Don't wait to see where industry or investors are going. Tell them where they need to go. Tell them your story. From your experience, whatever stage of clinical medicine you're at right now, you know more than they do about the depth of this. So start sharing that information. So real world evidence for those who are interested in that era. Advocacy for those who want to go and do policy. And then really thinking about industry and investors as people who are waiting for us to guide them to the right place.
Well said.
I know. I feel like that was the wrap up. I don't know what else I could add to that. I really appreciated you all taking the time to have such an awesome chat with me. I feel like I've learned a lot. I'm sure everybody tuning in has learned a lot. I know we have a lot that we have yet to cover, and I'm sure that this will, come into a creative series, and I'm sure you'll be seeing more emails from me about having a round 2 discussion. But this was just really wonderful, and I really appreciate you guys taking the time to chat with us.
Thanks for having us.
Thank you so much. It was a pleasure. I learned a lot too.
Yeah, great to be here, and hope your listeners enjoy it. Thanks for having us.
Thank you so much for listening. To learn more about the ASPC, please visit our website at aspconline.org.